Um, Hi, everybody. So, welcome to this next edition in a series of masterclasses. Today, I'm going to be talking about COVID-19, which is kind of the topic du jour at the moment. I'm Dr. Joshua Moon. I am a research fellow in the Science Policy Research Unit, also known as SPRU, which is a department within the University of Sussex Business School. Most of my experience is actually in infectious disease in one way or another. My undergraduate is not actually in policy, it's in biomedical science, during which I had a small focus on infectious diseases, and in particular HIV. During my master's and my PhD, I kind of refined that focus into the policy, and in particular the science policy of epidemic response and how that fits into how different countries respond to different epidemics in different ways. And so that's kind of what I'm going to talk to you about today, is this idea that actually outbreak response, and in particular COVID-19, isn't just a science issue, but it's actually a science policy issue. And importantly, it's an extreme form of science policy. It's not a kind of simple science policy issue that happens every day in terms of science informing policy in some way. And so to start, I'm going to kind of talk about a brief historical background, explaining a few decades worth of epidemic response events. And then we'll talk through kind of technological solutions, how they impact or change or shape the COVID-19 response in particular. And then after that, we'll talk about kind of decision-making under uncertainty. This is the idea that what do we do if not just our kind of view of the future from a policy perspective, but also the very science that we're relying on to give us answers is uncertain, is unknown at the time at which we have to make decisions. And that's the kind of policy process that fully typifies COVID-19 and mostly typifies epidemic responses in general. It's this decision-making under extreme levels of uncertainty, not just at the policy level, but at the very scientific level. And then I want to wrap up with this idea of using these technological solutions and decision-making under uncertainty to kind of make an argument about why different countries have such different responses and have had such different responses to COVID-19. So starting with the kind of historical background, I'm going to talk through a few different events that really impacted the way that we understand and think about epidemic response, infectious disease in the 21st century. So the first of these is actually the 1918 Spanish flu. This is a really common comparison with COVID-19 that happens in Western countries. This was occurring in kind of the middle of the First World War, and caused as many as 500 million cases, and estimates on deaths are somewhere in the kind of 50 million range. There are plenty of other estimates that differ from those numbers, but they all agree that Spanish flu was devastating. And so this is kind of this common comparator for COVID-19 in the West. One of the important things is that that actually led to the first ever large-scale disease surveillance effort. So post Spanish flu, the US Armed Forces actually implemented a system, an agency that was specifically designed to monitor influenza within the US Armed Forces. And that is kind of the very first view of large-scale epidemic surveillance and large-scale disease surveillance. And what's important, and what will become important as we go through this timeline, is that it happened in the US Armed Forces. It was not a public health focus, it was a focus on military strategy. And that's very important for how we think about disease outbreaks in the 21st century. Anybody who's ever heard the phrase the war on COVID, very much a route into this kind of US Armed Forces view. Almost 100 years later, we kind of step into the 21st century. And the 21st century is seemingly a century of epidemics. It's a century where our attention on epidemics and infectious disease is heightened. And part of the reason for that is that very early on in the 21st century, the world was hit by a new virus, and importantly, a new coronavirus that emerged in China, that very quickly transmitted across the world, hitting Hong Kong, hitting Canada, hitting Vietnam, cases seen across the globe, across different continents and countries. Anybody who is paying attention in late 2019, early 2020 will find that story very familiar. What's also important is that SARS kind of formed the blueprint for how we think about epidemic disease. And in this case, we as kind of global health in general. SARS was rapidly identified, it was rapidly sequenced in terms of its genetic code. And there was a rapid dissemination of scientific evidence and technical capacity to respond to SARS itself. The importance of SARS is not just that it set this kind of 21st century off on this pathway of increased attention to infectious disease, but that it led to the revisions of something called the International Health Regulations and formed the blueprint for how those international health regulations were revised. So in the 19th century, the 1800s, something called the International Sanitary Conventions were convened. At its core, this is basically a group of countries got together and said, we need to do something about cholera. And so they did. They agreed that they needed to ensure that quarantine and sanitation were implemented in each of their countries, such that they were then allowed, if cholera were to have an outbreak in one of their countries, to be able to restrict in some way travel and trade. But the importance being that throughout all the other times, travel and trade was protected. Over the years, those were transformed into what we now see as the International Health Regulations. These are legally binding international law instruments that dictate to states what is and is not legal and what is and is not required. In 2005, quickly following on from the 2003 SARS outbreak, what we saw was a revision of these IHRs which expanded their scope. So initially they were focused on cholera, plague, yellow fever, a general kind of specific, if you see a disease that's notifiable, you need to tell us, to what's now known as syndromic surveillance. This is basically this idea of all infectious diseases are fair game and we should have a continuous flow of data and actual kind of epidemiological understanding of what's going on in all countries at all times. What was also allowed was that the World Health Organization was empowered to act upon non-state information. This meant that the World Health Organization didn't need to wait for a country to say it has an outbreak before it can do anything. It also gave the Director General of the World Health Organization the power to declare what's called a public health emergency of international concern. The idea behind this basically being, this is the World Health Organization's panic button. If a fake, a public health emergency of international concern, is declared, that outbreak is something that the world should be paying attention to and should be worried about. And then finally, these revisions all required certain core capacities for states to actually build within their countries. And to date, less than 50% of states have fully implemented those core capacities. This is important primarily because SARS was forming the blueprint for what capacities states needed. It was forming the blueprint for WHO being empowered to act on non-state information, and it was forming the blueprint for why scope was expanded from cholera, plague, and yellow fever to all infectious diseases. It moved that scope. It allowed the World Health Organization to expand its purview beyond kind of these 3 notifiable infectious diseases to all infectious disease. And that's important because it means that not only is there more activity, not only is there more of a broader view, but there's also more attention on infectious diseases that may otherwise have gone unnoticed, or infectious diseases that may otherwise have not been notifiable. And that's important for this kind of long view of why the 21st century seems to be this century of epidemic diseases. 2005, for those in kind of Europe and America, was also the year of H5N1 bird flu, which harkened back to this kind of Spanish flu fear that a pandemic influenza will kill or infect the same number of people again. Following on from this, the international health regulations were first tested. So what was important about swine flu, or H1N1, is that there was early reporting and travel and trade restrictions. There is some argument or debate about the efficacy of travel and trade restrictions, and so there are questions around whether or not that should happen. But effectively, what this did was it led people to effectively be terrified of pigs. And so even following this, countries, for example, Egypt, culled all the pigs in their, well, I think Egypt was just all the pigs in Cairo, but led to this kind of mass, huge reaction. And then secondly, the emergency committee, so the actual kind of committee that's convened by the World Health Organization to determine whether or not this is a public health emergency of international concern, whether or not to hit that panic button, came under fire because a lot of the individuals within it had, or in some ways, had an interest in Tamiflu, or were accused of having interests in Tamiflu, which is a drug that treats influenza. And so there was some kind of issue with that lack of transparency, being this idea that perhaps there is a hidden agenda to declaring, to hitting this panic button, to getting countries to stockpile. And then finally, there are a few kind of communications issues, but at its core, and again, this comes back to this surveillance point, starting in kind of the military, is once you expand this view from particular diseases to all diseases, and you have the ability of the World Health Organization to hit this panic button, you really have this kind of huge emergency mindset that evolves out of this particular perspective of infectious disease. And we saw that play out with the culling of pigs and with the rush to stockpile. What we're seeing now with vaccine nationalism is a necessary kind of byproduct of this viewpoint, of this panic mentality. Following on from this, there are kind of 3 additional interesting events that I'm going to kind of whiz through. There was the 2014 Ebola outbreak, which I spent my PhD studying. The idea is, in this case, the emergency committee took its time. There was a huge amount of riots and resistance, and healthcare workers were killed because there was no real community engagement. And so there were issues bringing on board the actual individuals within the community who were needed to get this to work. Isolation and quarantine are big things within Ebola responses. And the rationale behind that, again, is breaking these chains of transmission, as we're seeing in COVID. But the issue is with a lack of community engagement, with international white people coming into African countries and saying, we're locking you in your homes because you have a disease. That's not going to get an excellent response from overall, or from the communities that they're in effect trying to protect. But because of that lack of community engagement, that lack of understanding about the community, it created problems. Second is the outbreak of Middle Eastern Respiratory Syndrome, or MERS, in the Republic of Korea. Again, we notice this because we have this broad syndromic surveillance view, and we have this panic view. But importantly, that panic view led to the government of the Republic of Korea withholding details from the public, panicking about panic, withholding details because they didn't want the public to know which hospitals had MERS patients. And that was problematic. What was more problematic is that local governments weren't even informed. And again, it's that panic about panic view. And so what we're seeing is this panic view, what we call a kind of security perspective, this view of a disease as threatening, as something that is to be panicked about, shifting the way in which we view and think about epidemic response. What was interesting about the 2016 Zika outbreak is that the panic response doesn't work for Zika. All of our responses were based on malaria, and malaria is vector-borne by a similar vector. It's a mosquito, as Zika is. But importantly, Zika was not causing acute problems. It was not causing disease immediately within the individuals that were infected. What was actually happening was that infants were born with something called fetal microcephaly, which is basically kind of birth defects. And it was causing long-term Guillain-Barré, which is an autoimmune syndrome. And in effect, the issue is that actually the care for Zika patients is long-term, it's not short-term. And so it's difficult for care systems, it's difficult for families, but that panic response doesn't work, because you can't panic about something whose effects are going to be long and drawn out. You can't hit the panic button about something that has a long-term response. You can hit the panic button and reduce the number of patients in this long term, but you can't actually hit the panic button for something that's going to take 20, 30, 50, 60 years to fully resolve. What's secondarily important for the next section is this idea that there was a heavy science response. A lot of institutions switched their virology capabilities to looking at the Zika virus. And this brings us to COVID-19. So the pathogen was rapidly identified and genotyped, just like in SARS, just like we were trying to do with H1N1, just like the virology capacity was trying to do with Zika. There was a rapid dissemination of patient care protocols and a PCR diagnostic test that happened within weeks. That's weeks, not months or years like this normally takes, weeks. And so you're seeing again this heavy science response based on panic. Panic and science, they go together hand in hand. Panic and technology, security and technology. You rush to science to give you this view of we have scientific, we have technology capacity that allows us to stop this panic. And importantly, we had treatments and vaccines in phase 1, phase 2 trials within a month or two. We have a vaccine in less than a year. That is astounding within the context. And so what's important about this whole process is that actually since 2003, most of pandemic preparedness has been waiting for this. We've wanted that rapid scientific response. We've wanted to hit the panic button quick. We've wanted to have that kind of containment and preparedness ready to go so that we can treat things, prevent them, and understand them as quick as possible. So why didn't that work? Why didn't our abundance of science and technology protect us from the thing that we were scared of? And that's the key. That's the key question that brings science policy into this, an understanding that science and technology need policy. They need social and political and economic systems to help them actually do the things that they need to do. And so what's important here is the technical response to COVID-19, how technical solutions develop, was incredibly quick. So on the 31st of December 2019, China was reporting cases of what was to become COVID-19 or SARS-CoV-2 in Wuhan. Within 2 weeks, the first full sequence of SARS-CoV-2 was published. 2 weeks, that's all it took. The draft was actually published, or not published, the draft was ready by the 2nd of January, 3 days. On the 1st of April, testing in countries like Germany was as high as 54,000 a week. And by the 1st of May, the UK was achieving 100,000 PCR tests a day. That is a rapid scale up of testing capacity within different countries, particularly PCR testing capacity. And then we come to kind of where we are now, which is on the 2nd of December, the UK becomes the first country to approve the Pfizer-BioNTech vaccine. Less than a year. I cannot understate how incredible it is that we have sequences published in 2 weeks, that we have PCR testing as high as 1,000 a day within months. Not 1,000 a day, 100,000 a day within months, and a vaccine in less than a year. Our technical response to COVID-19 is unprecedentedly quick. Comparing this to SARS, the initial 2003, the first case in 2002, it took 4 months to get a sequence, and we still don't have a therapeutic or a vaccine. Granted, that's because we're not hugely worried about SARS, and that the outbreak ended before we needed a therapeutic or a vaccine. With Ebola, the first known case was 1976. But the time to sequence, the time to the point where we had an actual genetic sequence, was somewhere in the range of 20 years. The time to therapeutic and the time to vaccine was 30. 1976 was the first known case. We didn't have a viable or approved therapeutic or vaccine until 2014. Well, 2016. Influenza's even longer. We've been co-evolving with influenza for centuries. And so we've had more than 400 years to sequences, therapeutics, and vaccines. Granted, that's a little unfair. You can't expect a 16th century scientist to be producing genetic sequences or vaccines. But to go that long, and in particular by kind of the 20th century, to have such an extended period of time before we get to therapeutics and vaccines, that demonstrates just how impressive the SARS-CoV-2 response has been technically. And so the issue is, if this incredibly rapid technical approach with fast sequencing a vaccine in less than a year and testing scaled up to high levels why were countries caught off guard? Why has there been such different responses? Surely we should have just all been working on the science and dealing with it as we can and moving forwards. And the answer comes down to decision-making under uncertainty. Because policymakers make decisions when science is uncertain about the nature, transmission, and dynamics of the disease. They have to. They have no choice. So how do they do it? And normally the way we think and the way we teach about how students think about the input of science into policy goes through a number of different stages. And in particular, these are tracked by how these models have evolved over time. So there is first what we call a kind of technocratic model of decision-making, where basically there are scientific facts, expert makes decisions, and those experts tell policymakers what those decisions are, and those are implemented. Experts define the ends, policy defines the means. What was realized, this was kind of the early 20th century view. What was then realized is that actually you also need some kind of social, political, ethical, and economic considerations in how science facts actually impact and change policy. So again, we have this view, this is what we call the decisionist view, but it's this idea that risk assessment science facts are plugged into the policy prism, and that those policy prisms are then used, the social, the political, the ethic, the economic, the cultural, all inform how science is then used to actually produce and create policy. What this is normally called is kind of the difference between risk assessment and risk management. What is the kind of the actual real risk, and what is the way in which you manage that? What followed this was an American adaptation, which basically looked at, well, actually, you don't just need to manage those risks, you need to communicate it to other people. This is much more your kind of 1990s, early 2000s model. The Red Book itself is a description of the book in which this model of decision-making was outlined. But there's one important similarity between all three of these models, and that is scientific facts exist. So within all of these models, science is assumed to have a single view. It is assumed to be univocal. And so the question is, what if scientists don't agree? What if there's uncertainty around how long an incubation period is, how long a transmission route is? What are the economic impacts? What are possible treatments? What are the testing strategies? What is best to do? What if scientists don't agree? Or what if there's uncertainty around those scientific questions? How do you actually make uncertain decisions? And so one of the ways that we teach is basically including a kind of coevolutionary view, which moves scientific decision-making from the input to a part of the process. And so there are social and economic and political considerations in the very questions we ask our experts. Framing assumptions, these ultimately cultural and economic and political considerations on why we think about things in the way that we do. Why do we put economic recovery above certain other aspects of recovery? And that then informs the questions that we ask scientists. Scientists are asked limited questions framed by social, economic, and political considerations that they then feed into a further set of policy decision-making processes. And so what's important about this model is not just that you've shifted scientific considerations into the middle, but that you have this reciprocal communication between all the three different boxes. Your experts are talking with the framers, those making the framing assumptions and those designing the questions, to help them design good questions to us. And the scientists are talking with political decision makers to help them implement and manage those risks based on technical as well as economic, ethical, and political considerations. And so the idea is that no single set of science exists, so you can't have it be the unitary input to decision making. And so you have to do this coevolutionary view. And that's why we see countries changing all the time, because the framing assumptions and the decision-making processes change as well as the scientific considerations. And so as science evolves, so do we. And so what this leads to is this idea of this is why countries have different responses to the same virus. And so what we can see is that it's not necessarily which countries are the most prepared. So this is the Global Health Security Index. This was compiled by a series of researchers who basically quantified how prepared different countries were. And as you can see, some of the most prepared countries, the UK, the US, if we look to cases, are not the ones performing the best. In fact, a lot of the oranges, a lot of the developing world is what is actually performing best in this view of cumulative confirmed cases. But what if there's different ways? What about different testing strategies? Can that explain it? Well, the countries doing more testing have more cases, but the testing percentage is similar. They're testing the same amount, but they're finding the same percentage of cases. And so they are actually having higher numbers of cases as well as doing higher numbers of tests. What about democracy? Could that have an impact? To some extent. Flawed democracies are doing worse than full democracies in most cases, and authoritarianism is to some extent helpful here, but part of that is this panic button response. But what's important here is not that it is one particular thing that makes a country successful, but it's a composite of all those factors. Science plays an absolutely central role in pandemic response. Technologies are developed incredibly quickly and were developed incredibly quickly for COVID-19. But the central issue was policy responses to the pandemic. And those policy responses are not solely guided by what people view as the science, but by politics shaping the policy choices. And importantly, that is not something that will ever change. It is impossible, because of scientific uncertainty and because of the nature of science's role in decision-making, to remove the politics and policy from how we respond to pandemics. We have to be able to not only understand the science and how that evolves, but how that science feeds into policy and how that policy is shaped by uncertainties in the science and changing political, economic, and social dynamics. And that is why, even with this hugely wonderful technological and scientific response, there are still huge problems within our response to COVID-19 and within our actual understanding and the differences between countries' responses to COVID-19. That's why COVID-19 is an example of science policy in extremis. Thank you. I am going to open this up for questions now. I'm also going to take a drink because there's a lot. So, questions. I have one here that is about learning, which is quite nice. This person asks, to what extent do you think countries will actually learn the lessons from COVID-19? Which, truth be told, I have some questionable opinions on, partially because I don't think that there is a single set of the lessons. Again, coming back to this view of science policy and how how politics and economics and social views interact with science, there's no single set of lessons for any individual country. And importantly, there's not going to be a single set of lessons for the whole global system. These lessons have to be adaptable and flexible to the context in which they're implemented. And so learning the lessons from COVID-19 is going to be somewhat problematic. Because it's not just that, say, the UK or China will have different lessons from one another, but different areas of the UK and different areas of China will have different lessons that they can be learning. But on top of that, there's a whole process that is required for learning to be said to have happened, because you can't just say, oh, we've learned things, we've learned our lessons. You actually have to implement and institutionalize changes. And the issue with that is that then also requires not just a scientific response, an academic response to kind of what are the lessons and what should they be, but requires a policy response to actually put those lessons into place, to institutionalize those lessons. So the UK has rapidly expanded its testing capacity, but it's done that by creating or privatizing most of the actual COVID-19 testing capabilities. And the question is whether that testing capacity is actually then going to be re-institutionalized within the National Health Service and Public Health England. Partially, there are some calls for that to happen, but also the open question is, does that need to happen? How do we do it? Secondly, there's the issue of these things tend to be forgotten very quickly. For emergencies and for crises, policymakers tend to have a somewhat short memory. They will have low-lying, long-lasting effects, but in terms of actual policy change, policymakers have short memories. And so actually institutionalizing the different ways in which countries could or should have responded is quite difficult, because there's no view or singular view for when those things should be put into place. There's no kind of, yes, these need to be put in place now. Because very quickly, COVID-19, as the vaccine rolls out, as cases start plummeting, you start getting fatigue. You start allowing that to move down the agenda, and you start focusing on other important things that are now more important, or that you view as more important. And so the idea behind all of this is that actually it's quite difficult to institutionalize lessons. On top of that, institutionalizing lessons is not necessarily something that everybody wants to do. There's still no kind of agreement on what the set of lessons are. We still have kind of the Great Barrington School talking about letting the virus rip or removing lockdowns in certain ways. But inherently, lessons look towards the future. And so lessons are a way in which we can understand not only our view of the past, but what we expect from the future. Our understandings of the past, if you think those are uncertain, our views of the future are even more uncertain. And that creates a real problem in learning lessons. Because to learn lessons properly, to institutionalize lessons, you have to get people to agree on what those lessons are and what they should be. And that's a problem, because not everybody's going to agree. And there's going to be critiques, and there's going to be problems, and then there's going to be debates, and that makes it quite difficult. But also, that has to happen. That has to be a mobilization of people. There has to be a discussion and a debate. And so do I think that countries are actually going to learn their lessons from COVID-19. I think they'll learn some of them. I think the technical lessons are going to get institutionalized. I think the view that vaccine production needs to be incredibly rapid is going to be institutionalized as a lesson. Upscaling testing capacity is going to be institutionalized as a lesson. I worry that some countries won't internalize the idea that isolation needs to be supported, won't be internalized. The idea that if you're asking people to self-isolate, that they need to be sure and secure about their income, their capacity to live, their capacity to gain access to medicines, to food, to water, are going to be secured. That needs to be in place, and I worry that there will be, to some extent, an overlooking of that fact, because people will be expecting technology to stop this from happening again and stopping the necessity for isolation support. So there's lots of different dynamics within this that are actually quite interesting. And one of the reasons why we, at least we at the University of Sussex in Sprue, and my team on optimizing COVID testing systems, OCTS, the project that we're currently working on, one of the reasons why we continue to do this work is because we truly believe that there needs to be this engagement with policy. And that's one of the things that we integrate really well into our teaching, is this need for engagement with policy, this need for communication across boundaries, to really give us a way to both institutionalize the lessons that we are learning from COVID-19, but also to discuss those lessons, to have those discussions and to force action based on those discussions. And so it does likely concern me that we're not going to learn the lessons from COVID-19, or that what lessons we do learn are not going to be effective in the next instance, or the next instance, or the next instance. Going all the way back to that kind of timeline I was talking about, a lot of the issues and a lot of the kind of discussion around each of these different events is, why didn't we learn the lessons from last time? And everybody puts it down to political will. It falls off the agenda, there's no political will. When actually the truth is, we are learning some lessons. We're just not learning the social lessons. We're not learning how to actually structure or maintain policy responses to epidemics. We're learning the science lessons and the technical lessons. Artificial intelligence is being invoked. We've got models everywhere for how the spread of COVID-19 could be predicted. But the actual social part of this tends to be ignored and eschewed. And so you run into real issues with how this whole process is supposed to come around. People now, we have a vaccine, are talking about logistics. What's the point of having a vaccine if it can't get to the people who need it, or it can't get to the people who are distributing it? And the issue is we kind of learn some of those lessons, but we don't learn all of them. It's a very kind of path-dependent view where we're learning all these technical and scientific lessons, but our policy responses remain in kind of the, partially with lockdowns and quarantines, our policy responses remain in the 14th century. So there's a lot to think about. I'm going to quickly move on to a second question before I talk too much on the first. But the second question is, to what extent do I think that the vaccine is going to have an impact on the current pandemic and how it operates? And effectively, I think it's going to have a drastic and radical impact. I do not underestimate the power of science and technology in responding to epidemic disease. The issue I have is primarily who gets it and access issues, because a huge amount of the, particularly the Pfizer BioNTech and the AstraZeneca vaccines, have now just been bought up by effectively the West. And so while it may end epidemics in some of these countries, the pandemic itself will be consigned to be ongoing. Access is going to continue to be an issue. And so what we're going to see is a huge, huge problem in kind of, it will disappear from much of the Western world or the Northern Hemisphere, but we will spend a lot of time trying to get access to the vaccine, to treatments, to capacity in the global South. And that all comes back to this panic button response. This view of epidemic disease as a national security issue. This view of epidemic disease as something that should be panicked about means that people panic, and governments in response to that panic try to bring to their people, their populations, the people who are electing them, vaccines, therapeutics, things that can be bought up quickly. And so rich countries are going to get the lion's share of it. And that's a problem, because so long as COVID exists in one country, it can move to other countries and still spread. There are complexities to that argument that I'm not going to go into, but there are kind of, in principle, so long as a disease exists in one area of the world, it can theoretically arrive in other areas quite quickly. Building up herd immunity through vaccination will help, but that doesn't stop it from re-entering countries. And so what we're talking about is actually that in terms of vaccines stopping the pandemic, I think for the Western world, that's going to happen fairly quickly. My issue is that for the global South, that's going to be very slow. Access to sufficient stocks of vaccine to create herd immunity, to do these types of things are, again, they're science policy problems. They're not scientific problems. And so they're infinitely more difficult to actually sort out, because the politics is at the front. And if the politics is at the front, more people can argue about it. Whereas if the science is at the front, then people tend to accept science as fact. So there's a whole slew of issues that I can kind of foresee happening, both in terms of learning lessons and in terms of the vaccine. But they all come back to this one central point across the entirety of this, this presentation, and that is that at its core, epidemic response is not just a science and technology problem, it's a policy problem. And that means we have to acknowledge politics, we have to acknowledge economics, and we have to acknowledge social and cultural factors and how they impact the response. Whether that be testing, vaccines, isolation, any form of epidemic response will create issues that are political, economic, social. And so you have to pay attention to those policy issues. You cannot create an epidemic response that is entirely based upon science, because the science is uncertain and there have to be economic, social, and political factors involved in framing those scientific uncertainties. And that's what's important, is that COVID-19 is not just a scientific problem, it's not just an epidemic in a technical sense, it is a policy problem that needs responding using a policy and politics view. And I'm afraid I have to go. I'm teaching again in 10 minutes. So thank you all for coming. I've kept up a series of links on the front or on the page where I've been answering these questions, to the business school, to my department, to Sprue. OCTS is the project that I'm currently working on, optimizing COVID testing systems. There's also a link to my own research and to my own Twitter if anybody wants to peruse or take a look or follow. And I'm always happy to discuss things with anybody, basically. I like talking, as you can probably tell. But thanks, everybody. It was good to see you all, good to see the questions. Goodbye.